in terms of the joint strategy. I think the finance and the IPQR have set some context, but I don't think they should overpower. I think the joint strategy. I'm not going to steal any of Pam's thunder at all. I'm just going to ask her to take us through the now approved joint strategy and take us through the key points and where we are. Thank you very much, Pam.
Thank you, everybody, and apologies for that very unladylike sneeze before the end of the committee. I'm just mortified, but at least I'm human, so I'm really pleased now to get back to what we're talking about and go through the paper for the joint strategic plan. A really engaged and very focused piece of work led by the strategic planning group, an engagement exercise that we took through the summer months, through a number of different fora to get the strategic plan agreed. So we took the strategic plan in its final version to the Joint Monitoring Committee, which is our overall governance jointly between NHS Highland and the Highland Council in terms of the partnership work. So really good for us to have a joint strategic plan in place that we can now go forward with and engage further with our communities and implement. So key to that implementation is, well, the committee will recall that we did have a development session some months ago around community planning partnerships and community engagement. There was an audit that had been undertaken. So part of making sure that we're delivering against that audit is to make sure that we engage with community planning partnerships. As a result of the joint strategic plan agreement, then we had a very focused session just on Friday there with our area and district managers in partnership with the council, and we were looking at how we set ourselves up for success in terms of that ongoing engagement. We've also this week had a meeting with the strategic planning group, so our multiple stakeholders across that planning group, which you'll recall is enshrined in the joint bodies legislation and within our partnership agreement in order to set us up and take that forward. During the summer months, we had very open engagement, a lot of feedback which has been incorporated into the final version that you have within your committee papers. A good frame and feedback from the community around affordability, about how we're going to implement the plan, some of the things that we'll need to consider across the district areas, some issues brought up in terms of equitable services, in terms of some services that are centralised, some services that are not accessible in communities, and also at the same time, in parallel, the Highland Council have been looking at the population changes, and within our if Tim was here, within our public health department as well, looking at the population changes that will impact on us going forward, and taking all of that into consideration. Also, there is the Highland Outcome Implementation Plan being renewed and refreshed across our public agencies and our public stakeholders. So a lot of setup for success, but the key for us will be in terms of the delivery and delivering on the aspirations that are within the plan. So Jerry, how much detail do you want me to go into in terms of presenting the plan? Has it to be presented to the committee today, or are people well informed enough, having had the development session in the previous version of the plan, to be?
I think Pam, for me, we as you say, just based on what we've done before and the fact that it's been circulated, we can assume a level of knowledge. I think you can take it through at a fairly high level in terms of principles and aims and how we and that important question, how will we know we will get there, sort of thing.
Yeah, so clearly, working well together across our agencies, this is not just for NHS Highland to deliver. Key within our stakeholder working with our partners, everybody bringing something to the table and getting there together is going to be really crucial. And we know that some of the challenges that we have are around workforce. That's something, and definitely around the affordability discussions that we had earlier on in the committee. So the plan itself is about health and care services, so making sure right across from learning disabilities to adult services, primary care services, drug and alcohol recovery services, everything that is within our business, making sure that we engage at all levels to deliver our plan. And clearly we've got some work that we've done within the organisation through our major redesign programmes in the North particularly, which who developed as part of their redesign the rainbow model. So that's really important in terms of how we set out our local care provision and how we wrap around that with remote consulting and monitoring, so that technology enabled piece, and how we make sure we get people to the right place, to the right care response at the time, right through to end of life care and hospital care if we need it. Right at the start of that, there was prevention, and I mentioned prevention earlier. So notwithstanding the challenges, I think we have had already the session to look at how we engage across the districts, so developing local district plans and agreeing a format for that this week with our strategic planning group, who met just on Tuesday there, and also making sure that we're in a state of readiness to underpin with the Highland Outcome Improvement Plan, and clearly, linking with a number of strategies that are in place. For example, our housing strategy, our carer strategy, the self-directed support strategy, our transport infrastructure and strategy. So very clearly working in partnership with the Highland Council to achieve our aims. So I'm happy to stop there and take any questions that people have, or if we can think about where we want to go next with the engagement and implementation of the strategic plan from a committee's perspective, to provide the assurance going forward, how regular we would want to have reports. We've agreed to go back to the Joint Monitoring Committee around March time, just to articulate the work that I was describing around the engagement and our role within, as a partner within community planning, how we will set up and deliver against our district locality plans, how we'll get to that equitable service and try and standardise our services across Highland, and start to deliver and implement the strategic plan. So I think I'll just stop there, and I think we can get into the discussion that will bring that out a bit more better. Jerry, thanks.
Thank you very much indeed, Pam. I'll just throw it straight open to everyone in terms of any comments, observations that they may have. And I think what we'll do is we'll maybe wrap up the discussion at the end with trying to answer Pam's question in terms of how will we as a committee receive reports, or what do we as a committee want to receive by way of reports as we move forward. It actually shows we are moving along that implementation journey, and I suspect the answer will not be a single report. It will be enshrined within our service strategy. But I'll kick off with Anne.
So it's great to have got to this point, and I think we should acknowledge the huge amount of work that's gone on to get the plan in place, the strategy in place, and it's super to be seeing it here as an agreed document. So I think that's a really important stepping stone for us as a partnership in place. Just some immediate thoughts in terms of Pam's question. I think that given the responsibilities that this committee has in relation to the Community Empowerment Act, as well as this strategic plan, it would be, I think, appropriate, useful to have a paper or a closer look at what Pam's just been talking about there in terms of localities and how our work across community planning, community empowerment, localising this strategy is going to interface. And so really the outputs from that workshop, which it's again great to hear has taken place about the locality approach. I think, you know, it would be good for this committee to hear in more detail what the direction of travel is intended to be there, and how as a committee those two responsibilities that we have might interlink. I think as I mean, you know, the strategy encompasses many aspects of our work, and it's all too easy in response to a large agenda like that to end up with a thin approach to implementation rather than a prioritised sort of and strategic focus for implementation. So I'd be quite interested to hear what Pam's sort of top three, you know, areas for the team think should be prioritised for implementation. Clearly, as she said, a number of the strategies that support the plan are already in place, but there's a lot of work to do there. So I guess I'd be interested to hear what her thoughts are about maybe, you know, the top three areas for further work in the coming year as the first steps towards full implementation of the strategy. And I guess for me, I'd be interested in particular to hear what our thoughts are about how we move forward with the issues around our care home provision and some of the very knotty challenges that we have there. I think our financial reports now, you know, are very clear about the implications of supplementary staffing in some of our smaller homes. So I think it would be really interesting to hear a bit more about that and what the Collaborative Care Home Programme Board is thinking in terms of next steps in relation to care homes. Thanks, Jerry.
Thank you. Pam, if I may, what I'm going to do, I'm going to bring Michelle in so we can maybe get a collection of questions that she can maybe just do in one fell swoop rather than joint it up. Michelle.
Hi, thanks, Chair. My question's about the district locality planning groups, Pam. One of the questions I was going to ask was, has work started within the communities to implement this service? But I think you just said that in March you're going to the Joint Monitoring Committee to discuss that. How are you sourcing the people required to join this group? And are you looking at rural as well as urban areas? And, you know, how is it going to be, you know, taken forward?
Yeah, thanks. So that's a really important question as well, Michelle. Thank you.
Could I just add one more onto your list there, your ever-growing list, Pam, which you can maybe think about? Could you give us your thoughts? And I know we've spoken about this before. Your thoughts on how we're then, within the context of the strategy, take forward our collaborative commissioning agenda. I'd be quite interested to hear about that, whether it be with independent or whether it be with third sector. And I don't need too much detail today, Pam, but just how that's going to encompass in that, and whether that will be a Highland wide or we'll actually be doing collaborative commissioning within a locality plan, sort of.
Yeah. Okay. No, thanks for that question. So clearly we need to articulate and agree an implementation plan. So looking at an overall project charter and a driver diagram that kind of simplifies what's in the plan, but gives us the key areas and the key work streams that we want to work on. The strategic plan itself, the implementation, really needs to be underpinned by you know, priority plans around you know, a workforce plan, also a financial plan. But key around that is looking at prevention and our technology-enabled care as well. So, for example, with our housing strategy, looking at the technology-enabled support that will enable people to live in their own homes and be supported at home. Clearly, what we want to do is enable people to live healthier, longer in their own homes. So our urgent and unscheduled care approach, if you like, making sure that people are not delayed at hospital, focusing on home as best, and wrapping around all our approaches to things like rehabilitation, prevention, and making sure that is really represented well and embedded within localities. So there's a piece of work in there about measuring where we are against our across our districts in terms of that equitable access. We do have a number of high level district profiles. We've already seen the very detailed ones that have come to the committee in the past, either in committee papers or through the development sessions, very much linking with our public health annual reports, so that we're totally looking at prevention going forward. So that engagement with our district managers, and clearly through keeping on the membership and the role and remit of the strategic planning group, so that they have the oversight and can be assured, you know, as well that we're developing and implementing the plan in the right way. So we've got a number of partners and stakeholders. If I come to the collaborative commissioning piece, we've got a number of providers who we are working jointly with, who we are looking at collaboratively commissioning with going forward to sustain the third sector. So engaging them in the test of change or the positive service redesigns that they want to do in partnership with us, so that we can maximise on everybody's input and ideas and get our planning right within our localities. I think there's a bit of complexity within, you know, if we've got district plans and we've got community planning, you know, that's very difficult for small organisations. So particularly thinking about our third sector partners, we're not needing them to come to 9 district locality planning mechanisms, 9 community planning partnership mechanisms. So articulating the strategy in terms of that overall plan and the implementation plan, we're going to have to be very wise and you know, think about how we engage with all of our sector partners to make sure, as we had a kind of strapline around the EQIA when we were out doing the engagement, is that we leave no one behind, you know, and that we don't end up just trying to implement something that would fit with a health setting and not jointly with the council, and also that won't fit with our partners. So articulating that in terms of that overall charter, if you like, about what our intention is in terms of implementation, and then being very clear that we're going to articulate the programmes of work that will support and engage everybody across the whole sector. We did bring a sort of outline locality profile, if you like, or a district profile to the strategic planning group as a first start, you know, a very early start in the new year. Once we got the plan agreed by the Joint Monitoring Committee, we had that meeting yesterday, so really focused on the district plans and the role of the district managers, if you like, as the conduit to make sure that they're engaging locally with their partners, and that we develop that mechanism so that we have an overall sense of the whole going forward. There has been that focused feedback in terms of our engagement about agreeing the strategy and developing it, about that rural versus urban and what we provide where, and obviously the impact of workforce and affordability. And if we look across a lot of the buildings, if you like, that we deliver services in, you know, a lot of redesign required, a lot of rethinking our approach around, you know, how are we going to absolutely support people at home, and you know, balance the demands and the complexity that we see coming towards services. you know, people are struggling in communities and need a lot more intensive support. So the workforce plan for me is going to be absolutely key in terms of how we develop our workforce, how we harness our capability and capacity across all our sectors to deliver our services and deliver those services to support people at home. We do have to look at our small care homes. They've been an aspect of sustainability for a long time in terms of, you know, the National Care Home contract. So if we think about a financial lens, then, you know, how much stability do our small care homes have? Do we have to look at, you know, where we maybe reposition care homes and work with the independent sector around what that might look like, and think about actually what's our reliance on residential care, and do we want to change models of residential care into supporting people at home, underpinning with that technology-enabled care. So an overall implementation plan, I would say in summary, fronted up by a charter and a driver diagram so that people can explicitly see the direction of travel and the key work streams that fall out of that. So where people can see where they need to engage, and it tells us and focuses us on how and where we need to engage outwardly then to make sure that we leave no one behind, and we underpin that with you know, our strategic commissioning and collaborative commissioning with our sectors, a workforce plan, a financial plan, and a technology-enabled plan, and all of those plans underpinning and interlinking with things like our housing strategy, our mental health and learning disability strategy, so that we get a sense of the whole. Now, that might sound very complicated, but I think if we start with the charter and the driver diagram and articulate the work streams, then those are the aspects that we will provide for assurance, so that people can explicitly see and be able to engage with the implementation journey and help us identify where we've missed things out, where there's gaps, where we need to prioritise other factors. So I think that's a kind of sense of whole to answer all of the questions, and hopefully I've done that justice, or if anybody wants to pick up any bits I've missed, then please do so.
Thank you very much indeed, Pam. Anybody, Anne, Michelle, or anyone else want to come back quickly? Anything Pam has said there? Anne?
So that was a helpful overview, Pam. I think my main reaction is how pleased I was that you started off by talking about prevention, because it's always very, very difficult to focus on that aspect of a strategy when we are so operationally challenged. But in the end of the day, given our context, I think that is the only way that we're going to break into this cycle that we're caught up in at the moment. So can I just say how pleased I was that you foregrounded that as for our implementation priorities. Thanks.
Absolutely.
Thank you very much, Anne. Diane?
Yeah, thank you very much. I think it's really positive to see the focus on district level working, which actually helps particularly remote and rural communities to feel that they are listened to. I suppose my question is essentially around engagement with communities. Obviously, we have engagement with providers and other people who actually are working in those communities. But I suppose my question would be, how can we evidence that we've actually engaged with the vulnerable, the disadvantaged, the more difficult to reach people, and so that their own needs and views can be taken into account? Because I'm not sure we can always rely on district managers to have an accurate picture of what those people think.
Absolutely, that's a great question, and reflected in the final joint strategy. Then we took a draft strategy to this committee and to the joint monitoring committee, and you'll see with the final strategy that we've given some engagement feedback, but we also have that ongoing look to make sure that we leave no one behind, and you know, that locality planning is going to be really important, and that's why we've been having engagement with the partners, with the council around community planning and making sure that we've got locality plans, community plans, district plans, that we hear the voice from the voices of people in our community. We did quite a lot of engagement over the strategy, but we still need to do that continuing engagement, that checking with the direction of travel. You know, what does this mean for you? And key for me, and some of my experience has been myself going out to some of the communities and you know, looking at data. You know, this is what the data tells us about your experience of care or your access to care, and does that resonate with you firstly? And what do we need to do to change and improve that? Or is there something that we're doing twice over, for example, and we perhaps need to consolidate a part of that service and join it up with something else, which might be where strategic commissioning come in. We work with a number of partners, and we do have good feedback mechanisms as well around, you know, our vulnerable communities. So linking very much in with public health, as I mentioned earlier, linking very much with our communities, making sure that we're discharging all our responsibilities under the Community Empowerment Act, and really being a very visible partner in community planning partnerships, where other agencies will bring that feedback to us. You know, the Scottish Fire Brigade, for example, are often out at people's houses doing community engagement. One of the strategic commissioning services that we have, the handy person contract, you know, they're out and in people's homes all the time, vulnerable people who are isolated and live on their own, and they themselves can be the vehicle of communication and feedback to us in terms of people, how they're experiencing services, and that route as well, about how we might bring information to them about how we're implementing the plan. Always not doing that in terms of digitally enabled or online services. We've learned, if we think about, we learned from our experience, people's experience of the vaccination service, you know, older people living on their own, not technology enabled or accessible, living remote and rurally. How do they go on to the national portal and book their vaccination appointment once they get their letter in to book, for example? So making sure that we're still providing traditional methods of communication and engagement, as well as people who are technology enabled, and we'll pick that up through different forums. So I hope that answers your question, Diane, and gives you some assurance.
Yeah, it does. I think it's a really important thing that we continue to provide evidence that we're still doing that. And can I just endorse something that was said earlier about the young people much preferring digital ways of communicating? That's certainly something I think we could build on and do more with, because young people also find it difficult to participate in traditional methods of consultation.
Yes, and I find it's a really interesting point, Diane, because when I've gone myself out to community councils, there's not a lot of young people sit around them, but obviously we're developing services for the future to make our future services sustainable, and they're a key stakeholder, you know, so we must actually, it's a really important point, we must make much more inroads to engage young people in terms of our strategic plan implementation, because they will be the workforce of the future, they will be the people who need care in the future. So as well as our current provision, we need to do that horizon work and work far more upstream, as well as in the prevention area as well.
Yeah, okay, thank you very much.
Thank you. I'll bring Muriel in, and then maybe bring this item to a close.
Yeah, thank you, Jerry. Thanks, Pam. Just briefly, we've been talking about community engagement and the CPP as well. You highlighted there the handyman or handy person scheme, just to be correct. But I am sure there are many communities and localities don't even know what that is. So how do we make sure that people are aware of the benefits, the that can bring? And equally, it has got a funding stream. So again, it appears, and we all know this, that there is a bit of a postcode lottery with access and supported services. So I think we need to share best practice, basically, and if it's working, and make sure that we can enable it to work in other places.
Absolutely. One of the desires and from our early surveillance and examination of the district profiles has been that need to make sure that we've got consistent services across our districts, that we have accessibility and equity. And you know, I think I've been using that term. It's probably a political term I heard somewhere or read it in the papers about levelling up, making sure that we're and I think the districts will clearly see that for themselves. You know, as we start to emerge with the financial plan and the workforce plan, they'll begin to see where some areas maybe have a bit more than them. So I think that will be a positive place for engagement as well, you know, with across the district, so that we get that horizontal integration and equity of services as much as we can, as much as is within our gift as multi-agency partners to get into that place.
Thank you very much indeed, Pam. So I think I think there's been lots of discussion about that, and I think the joint strategy is welcomed as a statement of intent of the way forward, and we look forward to, I think, thinking about how we might actually get feedback in this moving forward, Pam, and how we incorporate that into the work plan for next year. So we've been asked to, I think, note compliance in that we have an approved a joint strategic plan, and noting it's been approved by GMC. And I think we've been asked to accept substantial assurance here. And I think that's substantial assurance around the content and the existence of the plan. If I'm correct, Pam, are we happy to do that? Oh, so I see Neil has put his hand up there. Neil?
So one very quick question is, where are the public and we professionals going to be able to find the plan? I just hunted on Dr. Google, but I could only find the old Together We Care plan.
Actually,
so where can I point people to it?
I think that's a great question, because this week, you know, we'd come back to work after the festive break, and with just having the joint strategic plan agreed by the joint monitoring committee, we were straight into, oh, we've got this new plan. You know, we'd had a strategic planning group set up. We've set up with the district managers, and it did occur to me this week that I need to speak to our comms department just around how we're actually officially launching the plan. And taking that forward. And I see that Rhiannon's going to come in and maybe tell us a bit more about that, or give us some clarity. Thanks, Rhiannon.
It is on the website. It's on the NHS Highland website, under the Health and Social Care Partnership section.
But I guess we need to do more formal comms in terms of a specific launch, and bring it to life back to our communities. To show them the final plan, because I guess with our communication methods that we've just been outlining, not everybody will access that. And I was asked a question in the strategic planning group yesterday by one of the members around providing hard copies of the plan. I think just currently, I sort of was reflecting currently on the financial situation, so I think we need to maybe think you know, creatively about how we make that plan available to people, and I need to take that back to the comms department as well. So I'll do that. But that's a good question, Neil. I was thinking about that myself.
So we will leave that. We will leave that with you, Pam. We'll leave that with you, Pam. Louise, I see you've got one final hand in the air on this topic.
Yeah, just on that, I think we probably ought to just ask comms to put it as a link on the front page of the website, for certainly as it's launched, so that people can really easily access it.
Yeah.
Thanks, Louise. Okay, so we've recorded in the minute that we are accepting substantial assurance, and I'll have a discussion with Pam, and we'll reflect it in the work plan in terms of how we get that feedback. But I think Anne's earlier discussion point about the interface with the community empowerment is actually key to how we will actually move this forward. Okay, we're sticking with you, Pam. Community Services Risk Register report.
Okay, thank you. Now let me just get my hands on my little report. I've got so many documents open now for committee. Okay, so yes, thank you. So annually then we bring a assurance report to the committee around our community risk registers, the registers that we hold across our community health and social care services. So clearly we have a number of board committees where we have escalated NHS board risks that would be higher level risks. So across very, very broad but very important areas around, our workforce challenges, our financial challenges, our compliance with various different legislation and policy that we need to do, and our kind of mitigation plans as well. So they come across a number of board committees. So this is a very operational report then for the Health and Social Committee, Health and Social Care Committee, that outlines the risk registers that we hold across community services, also primary care services, and remember they include independent health contractors across optometry, community pharmacy and dentistry, as well as general practice. Out of hours primary care services, mental health and learning disability services, and adult care services. So within the community, we hold a monthly risk register monitoring meeting. So all of our risks are recorded on a DTIC system, which is a recording system, an inputting system. And we make sure that within the timescales of the mitigation plans that are represented against the risks, that they're reviewed monthly, so that we check that all of our, so from a governance perspective, then we check that they're all up to date, that the mitigation is in place. We look at adverse positions and exception reporting, which would go through to the community senior leadership team and the community, the Clinical Care and Governance Committee, and also the Health and Safety Committee, and likewise this committee. So what we've done is taken an assessment from the DTICS register then, just to articulate our high risks. So we've got two very high risks in relation to workforce, and particularly access to NHS dental care, which is notable and is often a subject of feedback. People's experience of services is often something that I'm involved with in terms of providing responses to and assurance to. And we've also had quite detailed reports around dentistry to the committee. So we've got 9 high-level risks then around our challenges to recruit. Some of the time we can on board. So recruitment is an interesting one, because we find that the workforce, if we look at the labour market and if we look at the employability within Highland and our competition with other sectors, then sometimes we're able to recruit to specialist workforce and other workforce who want to move into the area and take up posts, but clearly housing is a huge risk in terms of partners. So we've got some partnership work and mitigation with the council and other housing providers to try and mitigate against that. So recruitment itself is not just about our ability to attract workforce, it's about our ability to onboard them, which I think is a really important point to understand. That there are, if we actually solve some of the housing issues with partners then and work together in that space, perhaps we can improve our workforce recruitment and retention going forward. We still have issues in terms of statutory and mandatory training, but there's a short life working group and particularly focused on getting everybody up to compliance with statutory and mandatory training. And of course, with the way that we onboard staff, we've done a number of quality improvements around when people join the organisation, making sure that they start their statutory and mandatory training first, and that's monitored through the community leadership team. We do have issues around recruitment to particular posts, which means that people's experience in general practice. I mentioned earlier we've got 22 practices that our board run, around the model of 2C practices, which is the term that we use. And there's lots of issue of capacity, and there's lots of issues around buildings as well, in terms of how we deliver services and the estates, and the state and the upkeep and maintenance of our buildings, causing particular risks to care delivery. We've got risks of multiple care home closures as well, which the committee is well versed in. We've got some medium risks around, well, one of them is engagement. So the risk to service redesign due to lack of standardised community engagement. And I think we're mitigating against that quite well with the strategy and the discussion we've just had about the mechanisms and engagements we need to put in place, to make sure that we engage properly with everyone, including when we're doing service redesign. I think we've got some kind of risks, although we don't know the whole picture, but around the forthcoming National Care Service, where we fit in with that, how we engage with the developments there and the forthcoming legislation that may come, and that will affect what our services may be delivering in the future. We've got some inequalities in pay between health and social work professions, but we're working through them. I guess there's reputational risks as well, due to the governance arrangements in social work. We're still developing our care governance systems. They're much more robust than they were, but they need to be much more explicit. And I guess as a board, that the language of health and care needs to pervade. Sometimes the social work staff, in terms of their experience, feel a bolt-on as opposed to something being generated from source in their own professional right. So I've already mentioned dentistry in terms of the level 3 risks. In terms of the overall directorate summary, we've got health and safety risks, particular ones in terms of compliance at New Craigs with ligature compliance. We've also got a risk that we mentioned earlier around care at home staff, that Louise mentioned in her quality presentation, that not all of our care workers have achieved the SVQ qualification in the required timescale, so needing to mitigate against that and making sure that we respond to those challenges in the future. So just a summary of the overall risks around workforce availability, statutory managed training compliance, and the financial risks and the sustainability of our smaller care homes that I already mentioned, but we should be able to take care of that in terms of looking at the models of care with the joint strategic plan going forward. We've got a number of premises and accommodation risks. We've got a lot of older hospitals that are sometimes now not fire compliant or other legislatively compliant, that when we improve our IT systems across the care journey, then sometimes we're not able to install them. I think staff are still out and about working with very poor IT access, for example, in terms of connectivity. They may have the hardware, they may have the phones and laptops, but we're not able to connect into systems because of Wi-Fi, etc. So taking all of the risks into account and summarising them there, we can offer the committee moderate assurance around the processes that we have in place. So we've got a number of risks, but they're all mitigated, and we visit them regularly, and we have a governance process within the partnership to make sure that we're cited on the risks, that we understand where there's any variance. So I will stop there, Jerry, and hand back to you. Thank you.
Thank you very much, Pam. I think that was a very comprehensive run through the underlying risk registers. What struck me, I think, was the commonality of the issues and how often recruitment, workforce, or some other word appeared, but actually that was the fundamental issue in that, and from that so many of the other risks stem. So I think it just highlights the challenge of that. So, but actually I found the report to be incredibly helpful and informative, Pam. So thank you to you and your team for putting it together. I'll throw it open to questions, and I believe Neil has one for us.
Sorry, yeah. I guess I'm actually sort of bringing something else, something slightly different, but related to committee. Usually I go from this committee to general practitioner committees and talk about adult social care and all the issues therein. And Simon's been kind enough to come along and speak to, I can't remember if it's GP Sub or AMC, if I remember some of his favourite clinicians in his words. So, and when I look at this, I do wonder that, you know, there are a lot of awfully big issues there. Should I bring my concerns? And I think I should, if only that these are very recent, and I don't think are going to get onto the risk register almost until it's too late. And the issue I'm talking about is enhanced services. You might say, well, what's that? And I think it's worth explaining to committees so they've just got a little bit of an idea. Very briefly, independent contractors receive a block of income which is fixed according to national contracts. Additional to that is income resource to provide extra services, and part of that is decided by boards according to what they would like to contract from the independent contractors. Initially, these were idealised, I think, as pump priming funding, but actually very rapidly became an important part of general income to keep practices viable. And we run with them and have run with them, and a lot of them haven't changed for nigh on 20 years, despite a lot of discussions and you can imagine debates between LMC and board, etc. So 29th of December 2023, independent contractors received an email from the Primary Care Directorate saying, here are the new contracts which are coming into place on the 1st of April. You can sign up by the 1st of February or not, your choice. Some of them are reasonable, some of them are not, some of them have disappeared. This has gone down very badly with a lot, well, all general practices as far as I can see. People are very worried about being destabilised. People are very worried about being able to provide the care that they have been providing thus far in certain areas. And I'm not going to go into too much detail, but I would say, for example, diabetic care, we've got an obligation and we do provide certain level of care, and absolutely that's going to continue, but there are certain extra parts which we may not actually be able to do any longer. That hurts because that's not what I'm in the business of doing. And so you can apply that also to, there's dermatology, there's, for instance, basics, emergency care, which I don't personally provide out of this practice. I have done in the past, but certainly you would know on Orkney is probably pretty important. And out in rural areas is pretty important. And at the moment, that enhanced services, I believe, disappeared. So the thing about this is, if we wanted to get this into the risk registers through a DATIC system, it's going to be months. And we've got to make decisions, practice has got to make decisions by the 1st of February. So I'm really just mentioning it to committee because this is, after all, a governance committee with an eye to risks to the population. So what am I thinking? I'm thinking patients are going to be at risk. I've just mentioned diabetes, skin, basics, etc. I think there's a risk to secondary care because people, if they can't get whatever we need to give them in primary care at relatively low cost, they will be referred to secondary care. That's going to cost more. So that's the third risk, is financial.
Yeah.
Fourth risk is reputational, because this will become public. And finally is the risk to the discussions, debates and relationships between the independent contractors and the primary care directorate of the board. And I think that that has been harmed I can just say significantly. I don't know how we're going to fix this. I'm afraid I don't have answers, but I think that I thought that this would be an appropriate forum to make people aware. I appreciate in some ways it pales into insignificance compared with things which I hold really important, like adult social care, care homes, care at home, etc. But primary care provides incredibly good value healthcare, and I just think it's madness to cut it or to upset it. Anyway,
Neil, thank you very much for raising that issue or issues, because I think there is actually a number of issues in there. What I'm going to suggest, Neil, and I don't think you should be apologising in any way, shape or form for raising it. I'm going to ask Pam to take this away immediately from the committee and engage through the proper process. And my experience is that's generally through LMC when you want to have discussions of this type. But I will leave that to Pam and colleagues to work that through and actually to understand and hopefully resolve the situation which you've just brought us up to speed on. But I think we should, based on what I've heard Neil say, Pam, we should be adding that to a fairly high level risks register. And I think the highest element of that to me, and it's not to say that I don't evaluate anything else. It's actually that relationship with her GP colleagues. I think if we've done damage to that, we've got to repair it. So Neil, with your agreement, I'm not going to have any further discussion on it today, but I'm really going to ask Pam to go away almost immediately and understand and hopefully resolve this situation going forward, and ask that we probably get certainly I would be looking for a briefing outside of the committee, but at the next committee meeting we bring an update on this, on where we've got to. Is that okay, Neil?
Thank you so very, very much.
No problem at all. Thank you very much. Are you okay with that, Pam?
Yes, clarify a couple of points. Neil, you were talking about the communication coming out on the 31st of December and the impact. When Rhiannon and I drew down the risks from the DATIX register, that was on I think it would have been about the 3rd or the 4th when we come back just after the festive break. So in terms of getting the papers ready for committee, it wouldn't have been on there, but now we know it, we'll address it, and I will bring back an update in my Chief Officer's report to the next committee. I think that would be the right place to frame it first, and then from there we can decide how we want to hear more about this process within the committee going forward. Thanks.
Thank you, Pam.
Thank you.
Anne, you have your hand up.
So just as a word of comfort for Neil, I don't think you need to be concerned about raising that issue, Neil, and if you hadn't, I certainly would have, because it was raised at the ACF the other week, and I heard the discussion, well, not discussion, I heard the issues set out there. So I don't think you need to be concerned about having raised it. I think, Jerry, can we just emphasise that I think it's important, given the February deadline for acceptance or otherwise, and that we're not meeting before then, that you do get a briefing on the situation, well before that, if possible, so that you can be assured that appropriate action is being taken. Anyway, my was just very quickly, I wanted to return to Pam's comments about care governance, and just, Pam, if you could clarify where we're at in the process of improvement around that. Is it completed? Are we 2/3 of the way through? Where do you think we are on that journey?
So I would say, and I'll bring in Simon if he's still here, as the Director of Social Work and the professional who supports me and advises me accordingly. But I've been involved in the process myself. So Dr. Claire Copeland and our Deputy Medical Director working jointly with Simon and other relevant adult social care practitioners then. we've met and we've looked at the Vincent framework, the one that we've been using around our health, our partnership governance processes, if you like, to develop our framework for social care governance. Then we've engaged the Chief Social Work Officer in that. I think we're still looking to get more guidance from the Chief Social Work Officer that satisfies their statutory responsibility in terms of, you know, the assurance that she needs around care governance. So I would say it's still a work in process, Anne. I think we've got the mechanisms, we've got the meetings set up. We've got, I mentioned earlier around the quality and patient safety when Louise was presenting earlier, that, you know, we've now got adult social care practitioners and professionals around the table when we're looking at the quality and patient safety, particularly the detexes and all sorts of incidents and things. So we've got joint working there. So some of the elements are there and are robust. And we've managed to develop new systems and engage in existing systems, but I wouldn't say that we're 100% there. And I would ask Simon to give me his professional view then about what that feels like and how far along we are in terms of, I guess I'm trying to gauge a percentage of where we are in terms of implementation.
I'm liking the idea of trying to put a percentage on this. So just for the minute and for the sake of accuracy, it's 76.39% there, I would have said probably. Just to, this is an assurance committee, and it's really helpful that you asked this question, Anne, because equally there's a clinical governance committee taking place tomorrow where there's a question in relation to social work and social care governance. As Pam has said, the kind of weekly operational sift and sort of datex and issues that arise, and the quality and patient safety committee that operates for the Health and Social Care Partnership, I would give you comfort that that is operating better than it ever has. The sift and sort is operating in a way that enables the large number of datexes. We record every fall that takes place, etc. So there's a huge volume of these that come through. They're being sorted through in a multidisciplinary way that I think is very strong, and where necessary, they're escalated. But all professionals have seen what's coming through at the time to allow trends that might apply to either social work or pharmacy or whatever to be identified. So I'm going to give you comfort on that bit. And I would thank both Claire Copeland and Ruth McDonald particularly for the work they've done on that. We've made a number of proposals to the Chief Social Work Officer and the Chief Executives of the Board and the Council with regard to how we could take forward clinical and care governance. And the issue that we've got there is, I suppose, strictly speaking, it's probably threefold. The first is the Chief Social Work Officer has advised that the proposals made weren't entirely where she would wish to go with them, but we haven't got an answer at the moment to what would work. So that's the question I need answered. But on top of that, I think both of the chief executives were actually at the time were also wanting to examine this, and we're in the process now of 2 new chief executives, and I'm pretty confident that that's going to allow us to move that forward as well. So my expectation is that there will be a significant move forward. In terms of Pam's question, where does that leave us? I think where it leaves us at the moment is I maintain an uncomfortable position that because we haven't resolved the governance issues and we haven't resolved the escalation issues, social work and social care concerns do not get the level of attention or profile that, for example, clinical concerns get. I don't say that as a kind of bleat. I say that just as a fact, because the routes aren't clear for those to be addressed or raised. But I'm confident that, and I would say over the next few months, I would hope that we will be in a position to get a clearer structure in place. That's why I was saying it kind of feels like it's 3/4 of the way there. And to be honest with you, if I try and put a measure on it, but
I
I
don't
have chased
think I
down.
used the percentage
Sorry.
term. I think that was so. But was it 76.9? That's a very interesting.
2/3.
Yeah,
Three
you know me.
quarters.
I'm all about the data.
Okay, so well, I think that's very helpful. I think it's just important, Jerry, in terms of, you know, the initially sort of coming to this committee as our arrangements not being where they needed to be, that we, you know, when we think it is, the loop is closed 100%. Well, it'll probably never be 100% because this is an ever-changing picture, isn't it, in terms of the context we're working within. But, you know, I think it's just important that we close the loop on that eventually at one point, and it sounds like good progress is being made. So that's excellent. Thanks.
Hey.
Hi, I just wanted to ask about access to Datex recording for people who are out in the community. You know, I know that care at home staff and things have got the phone app that they use and things. Is there a button on there for Datex, or do they have to fill in a Datex when they get back to base? Or
it depends on the nature of the arrangements they've got for recording at the moment, Kay. Usually what's happening is it's coming in through the offices, and it's usually through escalation up through their managers.
I was just wondering if we're getting a true picture, because if staff aren't filling it in themselves, if it's going to management and then there's several loops there rather than somebody filling it in themselves. You know, that what you might be getting is, oh well, that happened yesterday, so we'll not bother. It's the same one again. Do you know what I mean? There's that sort of acceptance of things that happen in an agency. You just report the things that are really bad rather than, you know.
Simon?
Yeah, because of the range of routes that things come through, I would say that I'm confident, and because of the sheer volume that I've seen coming through, at one point, every Datex relating to social care was coming to me. I think it's quite hard to describe quite what a volume we're talking at. We've resolved that issue. I would say two things on that, Kay, and then if I may, Chair, I'd just like to answer Anne's final point there as well. So I'm confident that we're seeing an increase in reporting, and that may not relate to an increase in incidents. I just think we're seeing people reporting more and becoming more attentive to it. I don't see an evidence of dumbing down or kind of leaving it, because I think that folk are under pressure and they're actually realizing that Datexes are important. So my sense would be that I'm as comfortable as I can be at the moment that it's happening, and that there's not management barriers. I mean, that's the kind of elephant in the room for me. So I don't get the sense that there is, and the Datexes are actually followed up appropriately as they're required. Could I answer Anne's point as well, just about the pace of social work and social care governance? It's not just the bit about giving an assurance, Anne. For me, something also more important, we have to have our social work and social care governance in place, I think, for the next financial year, because the nature of the challenge and the level of the change that is required, and the questions that are going to be thrown up in terms of equity and efficiency of allocation of resources, and an ability to have conversations about variations in quality and outcomes. I'm sounding like a management book here, that can't be explained by population demographics, etc., are going to be absolutely critical. And I think if we haven't, if I could put it this way, the committee could not and should not be assured if we don't have those arrangements in place for the next financial year, given the scale of change that is likely to take place. And I'm happy to be held to account by the committee to report on that and give advance warning if I think there's a danger that we're not going to be there, if that helps. Because I do think it's got to be resolved quickly. Does that kind of get to where you're wanting to get to?
Thank you very much for that, Simon. I think you're absolutely right there. In times of big pressure is where your governance systems have actually got to step up and actually support the change that is required and make sure it's done in as equitable and as proportionate a way as we can. Louise, have you got your hand up, I see?
Yeah, sorry, it was just a point on what Kay was saying, because I think it is something we need to be mindful of. Actually, all staff should be able to fill out DATICs in their own right. I'm not saying all times everything. Certainly there's a responsibility on managers, but it's probably something, certainly from a health and social care point of view, we just need to be cited on that anybody and everybody should be able to, because the best account is from the individual. So I think it's probably just something we've got to have a bit of a think about as well, to make sure that we've got that covered.
Thank you very much, Louise. Okay, I'm going to move us on, because even with a shorter agenda, I'm performing appallingly today. So I've been asked to accept moderate assurance from the Community Services Risk Registers report. Are we content to do so? We are indeed. Thank you very much. Pam, Chief Officer's report.
Thank you. So me again, the Chief Officer's report, what I've taken to committee this time is just an update on the major redesign programme. So I think the narratives there, I've tried to summarise it into the bullet points just for ease of reading. So I'm not planning to go into them in any detail, but I think that does evidence that programmes are progressing, we're picking up exceptions, and we know what we have to do in terms of, developing workforce plans and engaging with all sectors, etc. So that seems to be, progressing well in terms of our major programmes across the Caithness redesign and the Lochaber community. So those are the ones that I've updated this year. Just looking out of my window here, and many people have been talking about it in the last few days, and Jenny referenced at the beginning, the weather that we're having. I live right on the coast, and I'm absolutely snowed in. It's unheard of to have such deep snow and high winds and drifting snow at the same time on a coastal area. However, I was on call, I was exec on call from Boxing Day, and I was in work between the days of the festive period, and dealt with Storm Gerrit. Well, I didn't deal with the agency, but what I have to say, and I think it's worth noting for the community, is that the way the community and operational teams worked well with their multi-agency partners to make sure that people in locations and care homes on the A9, and across areas where there was power cuts and people were out working in care at home, I think, testimony to the staff, real professionalism, real can-do attitude, people going the extra mile at a time when we were facing significant pressure with a storm on top, and people needing to have time off to be with their families as well, to celebrate, the festive season. So I just wanted to mention that to the committee, that the committee should take assurance that our care for people systems were stood up and were really effective, and that everybody was safe as a result of the terrible storm that we had across Christmas and New Year. So I'll just stop there in the essence of time, Jerry, and I'm happy to take any questions about the redesigns.
Thank you, Pam, in terms of your report, and I would certainly echo the tremendous efforts of everyone over the Christmas New Year period and the awful weather, and no doubt the efforts which are going on as we speak with the with the weather. Any questions for Pam? Anne?
Not a question, Jerry. Well, it's a request, I guess. I'm just wondering, I'm aware that there will be implications for the services that this committee is responsible for in relation to proposed changes in our vaccination programme. So I was wondering if yourself and Pam, when you're considering next month's agenda or next year's work plan, could maybe have a chat about when it would be appropriate to get a report from Pam on how that's going to be rolled out, and what the interests of this committee might be as opposed to clinical governance or any other of our committees. Thanks.
Yeah, it's on my ever-growing list of discussion topics with Pam, and so it's most certainly there.
As if she didn't have enough to deal with already.
She'll have all the answers. She always has all the answers.
Vaccination programme board at 4 o'clock, which is why I just shot off 5 minutes ago for a quick comfort break while the discussion was ongoing. So that starts at 4 o'clock.
Okay, we'll be done in a minute, Pam. Hopefully, allow you to get a caffeine break. I think we've been asked to consider the report and identify any matters that need further assurance or escalation. I don't think there is. Conscious I'm speaking on behalf of everyone else. So nothing that requires escalation. Pam, thank you very much for that report. Review of terms of reference. Ruth, if you're still with us.
Yep, thank you, Jerry. Yep, so at your last meeting, we considered some very minor revisions to your terms of reference, and your committee deferred full consideration of it because there was a request at that time for reference to be included in terms of the JMC's relationship with this committee. So what you have before you adds to the very minor revisions from last time. The bits in green are additional sections which basically set out the relationship with the Joint Monitoring Committee. So the wording has been lifted from the joint working legislation and the integration scheme. And I hope that sets out for you the relationship and the particular role of the JMC. I'm noticing from the version that you've got in your papers, I'll need to look at the numbering again because I'd included section 2 and I didn't then change the numbers of the remaining paragraphs. But other than that, that's the most substantive change that there is to this draft.
Thank you very much, Ruth. Simon, see you have your hand up.
Yeah, sorry, Jerry. I'm the most unlikely person to be a committee's pedant on this one. I think it's probably apropos the last bit of the discussion we had that it's quite important to note that once we have managed to clarify the governance arrangements for adult social work and social care, we'll need to then define the relationship between this committee and that. And also at the same time, and I can report this for you then tomorrow, the relationship with the Clinical Governance Committee as well, because there's a danger of an overlap on occasion or areas where they're crashing into each other. So, so my suggestion, Chair, if it's okay, is if you can make it incumbent on myself and to make sure I'm appropriately supervised, Ruth as well, that we report back to the next committee at where we're at in the development of that to further amend the terms of reference.
Absolutely, yep, that's no problem. That's fine.
Is that okay?
Yeah.
Thank you very much for that, Simon. I think the only other comment I would make on the terms of reference as they are is just to say you'll note, I think it's almost, if it's not the last bullet point, it's certainly down near the bottom, is we should have a commissioning subgroup, which as far as I'm aware we currently do not. Now my proposal is to leave that in our terms of reference at the moment, but I just like vaccinations, I want to have a discussion with Pam because I'm aware there is a commissioning group exists and I wouldn't want to reinvent something else, and it may well be we just have to do some reporting around about that. But I think in terms of our earlier conversation about the importance of strategic commissioning and collaborative commissioning, we probably just need a little bit more. So I'll leave it in there at the moment if that's okay, Ruth, but I'm not at the moment proposing that we will try and set up a committee, but I'll have a discussion with Pam as to how we best fulfil that commissioning oversight, so that may well require another small adjustment midway through the year or at the end of, or at this time next year. I'll be advised by your good self, Ruth, as to how that's best achieved.
Okay, that's no problem. Yep, that's fine.
So if everyone is content with those, I would propose that we adopt those as our terms of reference, and Ruth will take them through the remaining governance processes to get them in place for year 24-25.
I think Louise wants to come in, sorry.
Pam?
I think Louise wants to come in. She's had her hand up during the discussion on this item, I think, Jerry, sorry.
Oh, I don't know. Right, Louise?
And apologies, I'm not wanting to extend the conversation too long, but there's one aspect I do think we probably just need to have a little bit more discussion about, which is the folk listed under exec director, because it says nursing lead, medical lead, and there's I haven't got them open now because I've just closed them down. Was it
finance lead as well? Finance lead.
That's it. So I just wanted to say, I think we need to firm that up a little bit as to who we're meaning and what we're meaning by that. But I'm not planning on holding up the rest of the terms of reference. I just think we need a bit of an out of meeting discussion to agree who we're talking about in that form.
I'm going to be fairly bold and say I would be very happy to have names in there, and then an instruction is issued, all other things being equal, they're here. So, but I would be delighted to have a list of names rather than and I appreciate that there might be some chopping and changing and it might be jointly filled, but I would be delighted to actually add posts instead of names. So I think we can do that, Louise, but I think we're agreed in terms of we need that representation here. And if we could actually put names of posts on that would be ideal. So I think we're in agreement there.
Brilliant. It's just to try and get comparison with our other committees and equity with that in terms of, I know it's slightly different, but it's not that different. So yeah.
Yes, but it's not that, absolutely. Okay, so we'll pick that up as well with Ruth, and we'll try and get. Well, could I leave it to yourself and Pam then, Louise, for us actually to try and get, and possibly Boyd as well, to actually get names, and if we could get names in them before Ruth has to take them through the audit committee and the board, or I'm assuming is the next process. We can do that.
Right. Yep, that's fine.
Thank you very much for that.
Okay.
Committee work plan. We've got the committee work plan for our one remaining meeting of 23-24 there for March. And so are we happy just really to note and agree that's our work plan? I've already made one change to it, which I won't bore you with, but that's in terms of for March, but that's basically the outline for where we will be for 23-24. And as I say, what I'll be looking to do is to bring to that meeting would be a draft of our 24-25 work plan and a draft of our annual assurance statement for the year, which we will be winding up. So I'll be happy to note and agree the proposed work plan for the March meeting. Thank you very much indeed. Any other competent business? Thank you. I will note date and time of next meeting is 6th of March, but there is a development session on the 31st of January, which is going to be principally to talk about our assessment exercise, and Pam and I will get together and get a paper round to everyone with hopefully some thoughts and deliberations to allow us to move forward on that. So I'm not going to take any credit for finishing at 4 o'clock because we had a smaller agenda, but I will. It's a small victory. It's a small victory. So thank you very much indeed today. I think it was a really good discussion we've had today. And thank you all to everyone for their input. Bye-bye.
Thanks,
Stay
everybody.
safe.
Bye. Bye.
Bye.